finish off with Matt Graves addressing complex deformities with the clamshell osteotomy. If you have.
Okay, so appreciate the opportunity to talk to you guys a little bit about multiplanar correction in the femur. I think the previous lectures have been fantastic describing corrections in different planes, and this one is going to describe a osteotomy that allows for a little bit more utility in terms of correcting in all planes. So first thing I'd like to do is ask for forgiveness. This is one of my mentors. He was incredibly precise about the way that he planned and executed osteotomies. And what I'm going to show you is not so precise. But I think makes a lot of sense when you understand the history behind why this was developed. So at the end of this session, I want you to be able to understand the history behind the clamshell osteotomy. I want you to understand the simplicity that it provides, and I want you to be able to list the limitations associated with its use. So let's start initially with the history. So in approximately 2002, this is one of my mentors and current chair, George Russell, was the only orthopedic trauma surgeon at the only level 1 trauma center in Mississippi. So this happened secondary to the fact that he was recruited to join two other trauma surgeons at this center who left within 6 months of him getting there. And so this is a center that could easily have 5 to 6 trauma surgeons operating at the 50th percentile of volume across the US, and he was the only one there at that point doing trauma, meaning he was doing the work of approximately 5 or 6 trauma surgeons, and he had to figure out some complicated problems, and he wanted the most simplistic solutions possible, understanding that there was no trauma fellowship, and the most senior person on the service was a PG4 resident. So that's why the clamshell was developed, because he was dealing with complex problems with very limited resources, and he needed simplicity. So let's talk a little bit about the simplicity of the clamshell by going through a case. So this is a 62-year-old male. 30 years ago, he had a femoral shaft fracture. He has had left thigh pain for some time. He's been walking on this. But he's felt increasing difficulty trying to ambulate on this deformity. And so if we look at a problem list, he's a big fella, so his body mass index is greater than 40. He has a retained broken solid intramedullary nail, which creates some difficulties in terms of removal and correction. He has proximal HO around the intramedullary nail. He has a stiff non-union, so this is not very mobile at all. It's a stiff non-union. He has multiplanar malalignment, as we talked about before. At least the coronal and sagittal can be broken down into a single plane. The axial is a bit different, and he has problems in every plane. He has significant cavitation around the implant itself. And then he has educational concerns, if you will. He's relatively simple. I was worried about his ability to follow any type of complex postoperative advice, or even simple postoperative advice for that matter. And so I wanted to do something which was an acute correction as a definitive correction. I didn't think he would be able to handle any type of prolonged lengthening procedure. And by the way, while this case needs to be done, there are pelvic and acetabular fractures that need to be fixed in another room. And so, as you know, this talk was originally supposed to be a combination of a single plane mathematically derived osteotomy and a clamshell osteotomy. And so Sean Nork is going to cover the single plane mathematically derived osteotomy, or the single cut mathematically derived osteotomy, which was described by Sanjorzen and is incredibly elegant. You can define the sagittal and coronal plane deformity and the torsional deformity in a true angulation. You can define phi and theta, and you can create a very complex osteotomy through a very complex plan, and this is incredibly elegant. But I want to ask you a question. If this is the deformity that you need to correct, Do you want to use an elegant but complex mathematically derived single plane osteotomy with a limited margin for error? Or do you want to use a less elegant but simpler technique with significant margin for error? And I'll tell you, it depends on the day for me. I mean, there's some days that I'm really jazzed and I want to do something as beautiful in the operating room as I can possibly do, and I might be interested in choosing A. But that's not the question that had to be answered, really. It was this question that needed to be answered. So I want to ask you, how would you correct this deformity if you were responsible for this case and 10 others, including some associated acetabular fractures and complex periarticular work? And then to me, at least, the answer becomes significantly more clear. I'm going for B. And that was the genesis of the clamshell osteotomy. And so this is it. It is a subtraction osteotomy, if you will. So if we look at the images on the far left, this is your deformity in the AP and lateral. You make a transverse osteotomy cut above and below the deformity, and then you make a longitudinal osteotomy along the axis of the bone, and then you split that longitudinal osteotomy, creating what is akin to a clamshell. Symbolically, and then you use intramedullary nailing techniques and you fix the osteotomy just like you would fix a comminuted femur fracture using the same techniques. So let's get back to this case in the problem list. We have some complicated things that we need to deal with, and we want to make them as simplistic as possible. And so with any deformity correction, the first thing you need to do is understand the deformity and figure out how you are going to correct it. And so we break it down into the planes, the sagittal, axial, and coronal plane, and we define our deformity using the deformity matrix. So we think about translation and angulation in each plane. We'll start with the coronal plane. I want you to think about the complexity associated with preoperative planning and the time that it requires to spend with your patient and outside of your patient, outside of the operating room prior to getting there normally. And then I want you to think about the time you take to plan for a comminuted femur fracture using an intramedullary nail. And you begin to see some of the simplistic elegance of this procedure. So all of a sudden, you have decreased your preoperative planning substantially because we know that we're going to use an on-axis nail in this case. And by being in the anatomic axis, that's going to help us improve the coronal plane alignment. And we can use this contralateral side, which we can get intraoperatively in order to better define exactly what that means. When we move to the sagittal plane, it's really the same concept. You typically probably use the radius of curvature of the nail to restore a reasonable sagittal plane alignment when you're using an intramedullary nail for a diaphyseal femur fracture. And we are not going to do much different when we're talking about correcting this deformity in the sagittal plane. And a lot of that we can think about and do intraoperatively. In the axial plane, when you're doing a comminuted intramedullary nail, typically you're probably using something like cortical diameter widths, which are not terribly useful in this case, but you're also using things like a radiographic ruler on the contralateral side to define the length, and the lesser trochanteric sign, which you can define intraoperatively using x-rays of the contralateral side using your C-arm, and that will give you an understanding of the amount of length you need to correct and the overall rotational alignment that you need. So we have greatly simplified this case using things that we do on a day-to-day basis by using a surrogate of intramedullary nailing of a comminuted fracture. All right, so then we get to our surgical exposures. So in this case, the proximal surgical exposure allowed for removal of the proximal portion of the intramedullary rod, very simply, and the heterotopic ossification associated with this rod. The central surgical exposure, which was just a lateral exposure to the femur, elevating vastus lateralis, allowed for removal of the distal portion of this solid rod, secondary to the type of osteotomy that we chose to use. So the clamshell, which is done once again with 2 transverse osteotomies and a longitudinal osteotomy, allows for access to the intramedullary canal and creates, if you will, an intramedullary canal in an area in which one might not exist. So if you consider a non-union or a stiff non-union in a bone that was not previously nailed and the intramedullary canal is gone, then you create an intramedullary canal in that segment just by subtracting the segment, if you will. And so that was advantageous in order to remove the distal portion of this solid nail by direct access. Correcting the deformity is just doing what we would do for a comminuted femur fracture. We use an on-axis device and we get it in the correct position in the proximal and distal segments, and we bypass all of the comminution for the most part. And so that's what this osteotomy was designed to do. And in this case, we used a universal distractor, which has been shown in multiple other talks. This allows for length correction, but makes rotational correction a little bit more complicated. That can be done after the intramedullary rod is in place, if you will, preferably before though. And then establishing stability postoperatively is best with interlocking screws and the understanding that there is a great deal of load placed on this device. This is load bearing, not load sharing for an intramedullary rod because there's no bone contact secondary to lengthening in the comminuted central segment now. And so using things like multiple planes of blocking screws, multiple planes of interlocking screws, multiple planes of blocking screws, and additional fixation may empower your nail so that it will last during the time period of early bone healing, so that it can then function as a load sharing device once you have some early healing. So these are his post-op x-rays, 3-month post-op, 3-year post-op, and this is what he looks like walking 3 years after the injury. So it's not a completely perfect foot progression axis, but he seems to be pretty happy compared to what he was when he came to see us. And so hopefully at this point we can get back to the objectives. You can understand why the clamshell osteotomy was developed. This was necessity. So it's often said that necessity is the mother of invention, and for George Russell, who created this osteotomy, it certainly was. It was a necessary thing in order for him to be able to practice as the only trauma surgeon in a level 1 trauma center, which was the only level 1 trauma center in the state. I hope you can see the simplicity of multiplanar correction using this technique. It provides a great deal of margin, if you will. And so whereas some of the other osteotomy techniques require precision, I would argue that this does not require as much precision and can be done by someone who doesn't have as much experience in osteotomy techniques, but has significant experience in intramedullary rodding techniques. And so we didn't talk about the limitations, but I want to make those really clear. There's a reason that we're covering the clamshell for the femur and not the tibia. It can be used in the tibia and has been used effectively in the tibia, but because of the limited soft tissue envelope around portions of the tibia, it is more concerning. And so one of the things that we need in order to be able to use this technique effectively with lower complication incidence is the ability to access the deformity through a surgical exposure, an open surgical exposure. We need to protect the soft tissue. So just like Mark said many times in his lecture, it's very important to protect the soft tissue, not only the muscle and skin, but also the periosteum. So we want to be very careful with our osteotomy techniques. And for us, we're typically using drill hole osteotome techniques, but certainly we have a osteotomy saw as well that's used occasionally. We have to understand that this is a load-bearing device. This is not a load-sharing construct. And so early on, what we noticed when we lengthened significantly acutely was interlocking screw failure. So I would encourage you to place multiple interlocking screws and graft large defects that aren't filled by reamings using something else, whether it's something that's made in the lab or something from that patient. And then you have to have some expertise in metaphyseal intramedullary nailing techniques. So many times the osteotomy is extended such that you have a metaphyseal nailing procedure as opposed to a diaphyseal nailing procedure. And you have to be significantly, I would say, versed in metaphyseal nailing techniques if you're going to choose this for deformities like that. So there's some additional reading that you can do. The article on the right, which was published in 2010, provides more detail in terms of the technique of the clamshell osteotomy. The one on the left was a case series. Thanks for your attention.